So I'm Marvin Malek. This is part of the Northern New England Health Policy Internship Program. And um, today's talk is supposed to be an introduction to public health. But I just want to say I studied public health, and at least at Harvard in around 1990 when I was there, there were three major divisions at Harvard's School of Public Health. One was the biggest one of all was actually um, medical research, cancer research, a lot of it very basic research. And I believe that almost all or much of the tropical medicine disease research that occurs at Harvard, I think almost all of it is within the School of Public Health there. So that was the biggest division. They had the biggest building with lots of stories and lots of labs. And then the second biggest was the section that was working on the organization and financing of healthcare services, primarily in the US, but also abroad. And that included a fellow named Bill Shao, who was one of the team that designed Taiwan's healthcare system. And a lot of other people. And by the way, he was doing this major research on trying to come up with a payment system for doctors so that specialists wouldn't be paid so much more than primary care doctors. And he did it, and it's a very interesting research strategy that he used. But the specialists have had so much power within the medical establishment left over from those years when the AMA was at their heyday, like, 40s, 50s, that the battle never really got won to actually fully implement what Dr. Shao came up with. It's called the research-based relative value scale. Anyway, and I won't get too far into that at this point. But then the third and the smallest section or division at Harvard was what I actually call public health. And it's what I call public health, that is going to be the topic today. However, the internship as a whole, this internship is is the other one, which is the second one I mentioned, which is the organization and financing of health services, which is what you guys are going to be part of when you complete your training. So where will you work? Uh, what will you be paid? How will you be paid? Who owns the facility you work in? Do you own it yourself, meaning a private practice, or does someone else own it? And the question of who owns and how your patients get coverage to be able to pay for your care, and whatever other care, hospital care or nursing home care they need, that what is the system that uh, creates the insurance coverage and the infrastructure that you all are functioning in, will be functioning in. So that's sort of the main focus of the internship. But I just feel like we should at least talk about what the limits of medical care and how the medical sector of your work and my work, how that could fit into public health, and how to understand what people who are devoting their entire lives to public health are up to. And I have to tell you that when I got my orientation at the School of Public Health, on the first day, they said, okay, for those of you with an MD degree in this audience, which included me because I had already been to medical school, your projected lifetime earnings with this degree uniquely will decline. With this public health training, you're likely to earn less money than if you just didn't come. So you must be very motivated to learn about public health. And anyway, so that was kind of interesting. Then if I had instead gone for a fellowship in neurosurgery or orthopedics or something like that, I would have earned a whole lot more with that advanced training, but this one not going to get me there. I just thought I would throw that in. Anyway, I'll let's start talking about public health. I'll try to share the right screen. Must be this. Yeah, it isn't. Sorry for the delay. Must be this. We'll try that one. Working on the talk for tomorrow as well. Okay, so see what we got here. All right, so public health is defined as the science and protect and practice of protecting the safety and improving the health of communities through education, policymaking, and research on the prevention of disease and injury. And I am including injuries because in fact, what I did a fellowship after I completed my public health training. I did a research fellowship that was in the field of injury prevention. So we are actually looking at traffic for part of the year, traffic injuries, and you can design roads that are, over a 10-year period will involve fewer deaths of both occupants of cars and pedestrians. So you can undertake a variety of interventions. You can do driver education. We'll talk about some of the interventions, but you can look at injuries pretty much almost any injury type or disease type. Malaria is a great example because it has, it's kind of complicated and has a lot of targets. Um, so you can look at injuries and diseases and try to look at the populations that those diseases and injuries affect and do something about that. In that definition, what I said was improving the health of communities. So the word communities is really critical. And so the question is, who is the community? And if you're a researcher and you're interested in the most devastating diseases worldwide, which include malaria, HIV, and tuberculosis, you could say, well, I'm interested in the world, population of the world, and the if I want to improve mortality, it would seem to make the most sense to work on the most widespread, prevalent, and lethal diseases. So you could look at potential funding sources, and the World Health Organization and millions of funders in the United States. And you would find that a lot of that research, in fact, is occurring, but given the number of people affected by those diseases, there's relatively little research going on. HIV in the 1980s was somewhat of an exception, but that only happened when the HIV began to really impact highly developed countries such as France and Spain and the United States and several other countries throughout Europe. So the question is, who then selects the community? And you'll have a much easier time getting money for cancer research in the United States than to try to do malaria research in Burundi, and relative to their impact on the public health, the world, say. So what you can already infer from what I've said is that the selection of the target of study and research may be greatly affected by wealth, power, and and also community organization. So there may be communities that, I'll give you an example. There was, in Philadelphia, there was a community that had an incredibly high incidence of child pedestrian injury around a very uh, a road with very wide lanes that traversed a very poor community on the way to some middle and more upper class communities. And this was not an interstate type. This was a road with lots of retail outlets and stuff. So it was a complicated road that had multiple lanes, and it was so embedded in a community, a very poor community, that it seemed reasonable to try to do something about that. And so that was the community's point of view. But what had happened is that there was a bunch of researchers who were sort of public health people, and they had noted that there's a lot of violence in that community also. It had, a high homicide rate. And so the researchers had gone into the community wanting to spend money on violence prevention, but this community actually was pretty well organized. And they said, well, that's fine, but please do something first if you've got money for study and for implementing some intervention of some sort. Please do something, because our kids are getting knocked off by all these cars that are whipping through our community. And that's what we think is a real problem. And there have been like 3 children hit by cars just within the last 2 or 3 months at the time. So that was an incident when there actually was an organized community, and they actually had identified an important public health problem. And so the researchers actually kind of gave in, and they found a way to get funding for what it was the community wanted. So that's an example of community input rather than sort of funders directing research. But in general, funders, which means those with money, have a pretty big impact on, determining the vectors of what kind of research happens. But it's not 100%. For those of you who follow Bill Gates and Jimmy Carter, they both have funded a lot of studies in tropical medicine. Jimmy Carter, in particular, has been almost heroic in uh, doing a variety of interventions to virtually eliminate the leading preventable cause of blindness in Central Africa. And it's a type of parasitic thing called filariasis, I think, and I don't know much about it. We don't see, it's a exclusively tropical illness. Anyway, so you can get money to do international work, but at least before the Trump administration, through the National Institutes of Health, there was research money available. It's very competitive to get research grants. And the percentage of people who get funded before Trump was down to something like 35%. So you had a 65% chance of not getting funded if you proposed a research trial of your own, your own idea for some research. But 35 is not 3.5. And, now there's a 50% funding cut there. So that'll undoubtedly decline. Anyway, and also there's now a political influence over research directions. So now if you wanted to do a research project on disparities of care or diseases in the LGBTQ community, you probably would not get any fund. You'd have a 0% chance. So there can be political influences, and there always are to varying extents. But as I said earlier, research and interventions go better if the designated community wants the intervention. Let me just say one more thing about community, that it could be the whole country. So if you're doing research on the best treatment for colon cancer or the best way to prevent it, that your community might be the entire country or even, the entire world. So some research of common illnesses might go that way. Um, okay. So any questions up till now? I think this talk is kind of informal enough so that you can just interrupt me if you have any. It's just kind of slightly separate topics we're going to get into. I just wanted to introduce the concepts of need versus demand. So in this picture, the fellow on the right may well have any number of untreated illnesses ranging from hypertension to, heart disease, who knows, so cirrhosis of the liver, it's hard to know. Because a good chance the average person who's homeless for a great variety of reasons doesn't end up with very good access to, help medical services. And if he or she actually went to a doctor somewhere and got a prescription and an order for a lab test and an x-ray, you can imagine the likelihood of those testing and that being done and the prescriptions being filled and then taken. And if they need to be stored in a refrigerator, if it's like insulin or something like that, then, that's not likely to happen either. So there may not be much demand for care in the fellow on the right. On the other hand, the pair of fellows on the left, they look like they can probably afford to get medical care, and chances are they have coverage, and so they'll get the care they need, probably a whole lot more care than the guy on the right. So so the concept is the guys on the left with those suits, they effectively, if they want, they can have demand for care. And demand, I'm using demand in the microeconomic sense that they can access and they will be able to pay for the service, whatever the health medical service is. So that gives them demand. Whereas left to his own devices, the guy on the right may literally exert no economic impact on the healthcare system and its financing system. He'll have no impact at all. So he has no demand. On the other hand, if your need is a public health concept and and this guy on the right likely has a lot more unmet medical needs than the pair on the left. So, and need, if you spoke to the guy on the right, a portion of the unhoused population in the US has and abroad have severe mental illness, often schizophrenia, psychotic family of psychiatric problems. And if you asked him, and you said to him, you're like a public health person and working on the health of that community that he lives in, you could say to him, you need medical care. We think you need medical care. I have a record from a visit you made to a doctor 6 years ago, and you had very high blood pressure. So I have good reason to think that you need medical care. But he may say to you, I won't use the expletive, but he may say in pejorative terms, go away, just leave me alone. And so what I'm getting at with this conceptually is that need is determined by an expert, like a doctor, or like you can say to a patient, you've been having rectal bleeding for 2 months, you need a colonoscopy. But, that's an expert decision. And, whether that person has the insurance coverage or wants the procedure and has been effectively educated of the need for the procedure, that's another question. And so need is an expert term. And over the last 20 years, possibly due to the deleterious effects of the way the internet has come to work, there's there's we've had a cauldron of uh, anti-expert conspiracy theories, ranging from, recording devices and COVID vaccine, all manner of conspiracy theories to taking ivermectin or, hydroxychloroquine for COVID, just refuted interventions and skepticism that, are very difficult to unwind. The whole anti-vax movement is sort of built on that. And so it's, a public health expert can say that children should go through the usual schedule of child vaccination. And sorry that so many of them occur during the first year of life, but the kid's going to be exposed then, and that's when the illness takes place. Like pertussis, kids don't die when they're 4 years old, they die when they're 5 months old, and so you got to get the vaccine in early, and so you got the experts, and then the identifying need for care, and then you've got skepticism and whether there's going to actually be demand for care and people showing up with in money or insurance to get those vaccines that the experts are recommending. So this has become an increasingly big issue of, need skepticism of experts, including doctors. And it's something you're going to be contending with throughout your career. So it's an important concept too. So again, I'm just sort of getting toward the notion of public health versus medicine. And medicine walks both paths, especially if you enter the field, a primary care field, where you're thinking about the health needs as you identify them. And in primary care, you have to convince your patient that the needs you identify are important and to motivate that patient to have demand, effective demand. And so you're trying to provide preventive intervention, whether it's screening for high lead levels in a child or, providing a pulmonary function test for a person working in a coal mine, or even treating high blood pressure, because that's usually asymptomatic, doesn't lead to symptoms. So there's a lot of public health going on in primary care, and it kind of walks a line between the two to some extent. But I think technically, at least, even primary care falls within the medical model. So you treat the people who show up in your office. That homeless guy is probably not going to show up in your office. So he doesn't have effective demand for a variety of reasons. On the other hand, intelligent rich people who don't buy into conspiracy theories, they'll really show up in your office. They'll come for their scheduled visits. And if they have diabetes or high blood pressure and you're in primary care, you probably can accomplish a lot. So, they have good health insurance and all that. So it turns out that this medical model of treating people who show up is contractual, that once it's established, the patient is on your schedule, and they're your patient, at least that day, you have a duty to provide care at the community standard for doctors in your community. So you don't have to provide necessarily the care that the most highly trained specialists at Harvard would provide, but you got to provide reasonable care, reasonably good care. And you have to respect confidentiality, and you try not to factor whether you think the patient can afford the test you're proposing, that you're supposed to recommend what you think is the best intervention. And we can say more about that, because I can tell you one thing: when you're practicing in general, regardless of your specialty, I strongly recommend that you always tell patients what you think the best diagnostic and treatment plans are. And don't withhold them because you know the patient doesn't have good health coverage. Even the poorest people who don't have insurance, who are probably going to not accept the best treatment you know of, they still want to hear about it. So just keep that in mind because it may be that no one else will tell you that, but I've had so many patients say that that person just thought I was poor and never told me what the best treatment was. So, just tell people and then say, give them a sense of what, you can do a financial analysis and propose a less expensive option, but always let them know if something is clearly better, then you should inform even the, poorest person who has terrible insurance and all that, because it's just the right thing to do. Anyway, but it turns out that it's contractual. It's not really different from the contract between a client and an accountant or a client and a lawyer. It's a relationship, and you can get out of it. You can exit it. You can say, okay, you've missed 3 scheduled appointments. We can't keep holding time slots in my schedule because other people really need to be treated. And our wait time to get any appointment is a couple of months. So you keep taking these slots and not using them, so you're out. I'm just getting rid of you. You're gone. And then you send a certified letter to the patient. And at that point, they're you have no duty and you're not their doctor anymore. Okay. So that can happen. In the Alternatively, the patient can do the same thing. So I have a personal history of getting really crappy medical care. And even recently, and I just let an office know, orthopedic office, say that I won't be going back. And so they can sort of take me out. There's no more duty to provide care to me because the relationship is gone. However, in public health, it doesn't go that way. So let's say you were back in Philadelphia and you did both projects to prevent violence and to reduce the number of child pedestrian injuries. Um, Nobody in the community gets to really sign up. It's sort of a community study. You're studying that population. You're going to look at the number of child pedestrians who were hit, the number that had to go to the ER, and the number that died. So, that's what you look at: number of events, number of injuries, number of deaths. This is how a lot of public health research classifies and tabulates what they're studying. And so that all can happen. And if a child got hit by a car and died, they simply wouldn't be excluded from the data. And similarly, the child that was destined to get hit by a car in 2 years, that child doesn't even know that. And your intervention's goal is to prevent that event in the future. So there's not really volunteering. If you actually implemented an effective program, putting in speed bumps, maybe even getting rid of a whole lane on the road, because the more lanes you stick in there, the faster the traffic will go. You could do all kinds of things to make it safer to cross the road and to slow down traffic near intersections. There's a variety of interventions that can be done. You can put more signs up saying, slow down, or whatever. And so anyway, there's a variety of intervention. You can teach children to not run into the street after a ball. That's been the classic, and that's a classic injury for children between 3 and 8 years old, that they run into the street after a ball and get hit by a car. So there's been educational efforts to educate, children at least ages 6 through 8, so they shouldn't do that. Anyway, so there's different types of interventions, and you generally try to treat everybody in you're defining as being your community. So it would be, say, every child, between ages 3 and 18 who lives in the community is your target group. So again, it's not, for the most part, not voluntary enrollment in the research. Any questions? Okay. So let's just take an example. Let's look at COVID. So at the time, before there were testing, very early in the illness, it was a difficult diagnosis. That changed, and it became a relatively easy diagnosis that people could even make at home. So that was good. Unfortunately, the interventions, the various medications to treat an ill patient who's sick from COVID, they're actually incredibly minimally effective. They're like really minimally effective. Even the ones done for the sickest patients, it's pretty marginal. I mean, if they're 20% effective, I'd be surprised. Anyway, so you've got a disease that's really hard to treat. And on the other hand, the public health measures were dramatically effective. If you isolate people and they stay at home, they're not going to catch it. You know, they have 100% chance of not catching it. If they get, finally a vaccine was discovered after about a year, and if they got the vaccine, they pretty likely not to die. So even older people. So you have these various public health measures that are dramatically effective, but look what happened. You know, there were movements to make it so you couldn't force kids who didn't even mind wearing a mask, you know, at an age where they understood it and they were willing to do it, where it was like banned and, you know, in schools in some states. So here's another example of a public health, an obvious public health measure just being blown off by sort of political convenience and opportunism and conspiracy theories and, you know, just all kinds of stuff, political factors. So, you know, all the public health interventions added together worked really well. Distancing, quarantining when necessary, using masks. Building ventilation is incredibly effective. It really works, prevents, you know, maybe as much as a third or half the illnesses in a beautifully ventilated building. You can hold events outdoors, close very risky businesses like bars where everybody's cramped together with low ceiling, you know. You can cancel concerts in certain situations if there's a particularly bad outbreak. Um, and then you can they developed wastewater evaluation so that you could look at the concentration of COVID in the waste, in municipal waste, and get a sense of when the disease was coming back and potentially use that to inform an intervention, some of the previously mentioned interventions. And then finally, you know, a lot of public relations to try to counter all the conspiracy and um, you know, the skepticism that inevitably develops with these major public health outbreaks. So, so the public view is when, now let's look at it from the point of view of a patient. When you're comparing public health to medical interventions, which were popular? Did the individuals who would have died but didn't die because they got a COVID vaccine? In fact, they stayed at home because they never even got sick enough to go to a doctor because they got vaccinated or they stayed at home. Did they ever thank anyone, any public official or public health department? No one got thanked ever for preventing public health. Even in New York City, when the people were banging on the pots and pans at 7 p.m. every day, it was to thank the doctors who were treating the patients in the hospital, which is fine. I worked during the whole COVID period, and every day I went to work thinking, you know, am I going to die from this illness? Like I have this N95 mask, and I'm like, I can kind of tell that it's not 100% effective, and you know, and I appreciate it if people, I mean, I'm up in a rural area, so nobody banged on anything here, but you know, it's kind of nice that they expressed appreciation down in New York City and, you know, whatever. Um, but did the individuals who would have died but instead contracted a milder form, you know, did they thank anyone? That's a no. Did the patients and families thank the doctors and nurses? Okay, so I can tell you that answer. Um, we treated a lot of COVID patients, and they were profusely appreciative. They said, "Oh, it's risky what you're doing. We really appreciate it." Giving them these treatments that are like marginal. I mean, the most effective thing that went on, if you really look at the medical treatment of COVID, was not an anti-COVID drug, but was giving them oxygen so that their own immune system had several more days to figure out how to organize itself and implement an effective immune response to control COVID. That's what we did that really made a difference. So somebody was so hypoxic that they couldn't live anymore. If I gave them high flow oxygen, maybe you could give them 6 or 8 days, and they could live. So, they were saying thank you, and it's fine. Sometimes patients say thank you. I never expect it, but and it comes my way, it's fine. Anyway, so the community for the public health intervention part of this, which was dramatically effective, was unwilling, angry, quote, patient, while the patients, who were getting this modestly effective treatment, they were like enormously appreciative. So this is what goes on. That's why it's nice. That's the nice side of practicing medicine. So there have been studies of the contribution of healthcare to longevity, and a variety of techniques have been used, and I'm just summarizing it here. This is really a gross estimate, but at any rate, medical care seems to prevent about 15 or 20%. Behavior like not smoking prevents maybe 30, and social determinants of health, something like 50. I'm talking about premature preventable stuff. I'm not talking about, if you look at overall mortality, 2/3 of it seems to be random and unexplained. So in other words, a friend of mine got some weirdo gynecologic cancer and ended up dying of it. There's no known preventive anything. It wouldn't have been detected with pap smears, so 2/3 is random, but among the third that is felt to be preventable, um, it divides up about medical and versus behavior and social determinants of health. However, a lot of the interventions to change behavior and even to refer the patient to a social worker to work on the social determinants of health, they can be taken seriously and worked on in a primary care office. So a high quality primary care practice will be working on all of those, not just the medical part of it, whereas a vascular surgeon is doing only medical care. The primary care doctor who sees the patient with peripheral vascular disease will be talking about exercise and improving diet and all those things that affect the deposition of cholesterol into the peripheral arteries. Whereas the vascular surgeon is more of a technician, might be bypassing the artery when things go bad. So anyway, so that's sort of a general breakdown. So now here's the prevention strategies. Primary prevention is when you keep the disease from developing at all. So that would be a measles vaccine. Secondary prevention would be to mitigate disease from getting bad. So that would be a COVID vaccine. So the measles vaccine prevents, for the most part, prevents you from even getting the illness. COVID vaccine wasn't that good. It didn't prevent people from getting the illness, but it did prevent you from dying. So secondary prevention of death from COVID was having gotten vaccinated. And on the public health side, if you persuade a child to never start smoking, that would be primary prevention. If you get a person with bad COPD to stop smoking, that's sort of secondary. And then tertiary prevention would be to, take somebody who had advanced COPD or lung cancer and try to treat it and send them to pulmonary rehab where they can function a little better with the severity of disease. So, and I'm getting tertiary prevention now, going to rehab for, my shoulder issues. Anyway, so that's sort of a concept of what type of prevention you're doing. And this is, anybody know what this is? It's a truck. It's the back of a truck. Come on, guys, you know what this is. You've seen this, I guarantee it. It's mandatory in every truck, a truck of a certain height in the United States.
All personally, I've always thought that was like a footstool of some sort to, step on to get into the truck. But seeing it in this perspective, maybe not so.
That's a great answer. Thank you so much for saying that. It's not that, though it's it probably has been used hundreds and even thousands of times. But I just that's a great answer because I just love honesty. Anyway, yeah, this is a public health thing, and it got required when there was a series of more than average publicity for an accident type where a car going way too fast rear ends a truck, and the whole front hood of this fairly small car ends up underneath the truck. And that creates really, really bad injuries in a rear end collision. So they started requiring these things, and that really helped. They still had a crash. You know, your car still got wrecked, but at least the person inside the car tended to not get killed. So it mitigated illness severity. So on that chart, what would you call this? Would this be primary, secondary, tertiary prevention of, say, traffic death?
Maybe secondary, this would
Yeah,
be.
I go with secondary because the accident's happening and yet the person doesn't die. Yeah. So anyway, so and I don't remember what the name of those things is, so somebody can figure that out. But anyway, so a fellow named Haddon developed a matrix, a 3 by 3 matrix, to sort of help a public health professional think through a problem. So what we have here is the Haddon matrix applied to vehicular crashes. I think Haddon actually worked in the field of vehicular traffic. But if you go through this, you could apply this to COVID or malaria or tuberculosis. You could work with this graph. Like let's try it for TB. Like a pre-event, before the event even happens, what could you do to prevent tuberculosis? Let's say a primary prevention. What could you do if you knew there's TB in the community?
Maybe for starters, providing PPE to healthcare workers that are working with affected patients.
Yeah, you could do that. And you want to call that one primary prevention so the healthcare workers don't get it at all?
Maybe secondary. Maybe that's like a
Wow.
1.5% prevention or something.
All right, I'd go for primary, but the whole point of this graph is to help you think of things. So, uh, what could you do with once the what could you do pre-event to make the host, the patient, more resistant?
You give vaccines.
Yes, you could try to develop a vaccine, and there is one. The problem is it doesn't work very well. It's given in India. It's called BCG, and it's only modestly effective. I think in India, where the prevalence of TB is high, it may be worthwhile. But what happens when you get that vaccine? Then, when you get screened for tuberculosis, as long as your immune system is working, you're going to show up positive. So there's no way to know about disease activity because the people who are exposed and have a beautiful immune response and never get sick have the same test result after that vaccine as someone who's very ill but who still has a functioning immune system. So the skin testing, which has been such an important part of case detection, so part of addressing tuberculosis in the community is identifying cases. And rather than having to do a chest x-ray in every single person, you can do this skin test. And unless somebody has a wrecked immune system, the skin test should be positive if they've been exposed to TB more than, a couple of months earlier. So you could screen a community for tuberculosis and identify the people who are positive. And it turns out if your chest X-ray looks perfect, but you've acquired a positive skin test, as I did when I worked on the TB ward at the county hospital in Chicago, there's a regimen of 6 months of taking one medication, and that has the ability to kill off the organism. Whereas if the patient has active illness, they usually need multiple meds simultaneously. So you could do screening to prevent active tuberculosis in the population. Let's do one for malaria. Did you know that you can breed sterile mosquitoes and then release them into a swamp or something, and then the population of mosquitoes can go way down if you can release so many. So that's a preventive intervention for malaria. So, but I think the general idea is, and if there's time today, we can have you guys do one, because I don't have a whole lot more. It just gets you to think of how to mitigate, what to do about the person who's coughing, what to do about their TB organism. You could develop an effective treatment that wasn't so complicated that you had to use multiple drugs. There's all kinds of interventions. And this, again, this matrix helps you to think them through. So I think I was going to talk about, so what an environment, okay, going back. So environment turns out to be the most complicated one. It could be the physical environment, like do you have roads that are hard to drive on? Or on the other hand, did you put in a speed bump to reduce traffic speed in a populated area? You could do legal interventions like enforce DWI and speed limit laws. You could do a social intervention, like making it socially acceptable to have a designated driver who's not going to drink at the party that a group is going to. So that's kind of a social intervention. And then you could have an economic intervention for building roads that are safe, funding roads that are safe, and building a public transit system. I mean, you could call that a physical one, I suppose, too. But anyway, and in the area of tobacco, the economic intervention was very important. So this is an example of a public health campaign. This was the 1950s. You can kind of tell by the way people are dressed. And the problem for the tobacco companies, by late 1940s, the prevalence of smoking among men was way higher than among women. So that was unacceptable to tobacco companies. So they had to try to get women to smoke. And these were some of the early attempts. And they even were willing to enroll to try to get minority populations to smoke. Because at first, especially among women, they weren't smoking very much. Try to make it sexy and acceptable for women to smoke. Have even doctors who were extraordinarily well respected in the 40s, after what they had done in the war effort. More doctors smoke Camels. These were real ads. I'm not making this up. This is real. More doctors smoke Camels than any other cigarette, or Luckies, same thing. And it didn't have to be true. And so here's again more efforts to get women to smoke and minority populations because they weren't smoking enough. So by the 1950s, there were since the tobacco smoking rate had been increasing during the 20s, especially, and the decades beyond, unprecedented levels of tobacco-related illness. What you're seeing here is a lung that has that big white thing with a necrotic area in the middle. That's a lung cancer. It's about to compress some of the bronchial tree. So that's pretty bad. It's probably not treatable anymore. And so we had to stop that because it was becoming incredibly, very high incidence stuff. So this is going to be a multifaceted campaign. Every part of that Haddon matrix got used. The Surgeon General put out a heavily publicized report in 1964 that back then got a lot of publicity, and you had a Surgeon General that people actually respected. Anyway, so there was multifaceted educational campaigns, TV ads, brochures in public places, it was all kinds of things. TV spots describing the dangers, and then the radical neck lady, who I'll show you later, she was really scary. Ban on tobacco advertising on TV, on radio, and on billboards, that they weren't going to be there anymore. And there were heavy taxes, a big economic incentive, which turned out to be especially effective for people under age 20. You make them pay more for cigarettes, they're less likely to do it. Ban on, and then there were prohibitions on airplanes. I was like so appreciative when that one happened because I have lots of memories of the whole back of the plane being like needing to be fumigated. Anyway, but restaurants, they started banning it in restaurants and even in some outdoor areas. And then enlist doctors. So it turns out that if you're a smoker and you go to a doctor, and the doctor says, and in a very neutral, non-judgmental way, it'll be really good for your health if you quit smoking. And I'll try to help you if you want to. That statement apparently has a 7% effect. It has a 93% of not working that day or week, but it has a 7% effect. And when you're talking about, millions of people smoking, if you get the doctors to make that statement, some of them will actually quit. And the doctor, now there's stuff to prescribe, that can help them. So here's the report, carefully researched study. And, it generated a lot of messages and all that. So here's the kind of ad you started to see. So here's a black guy who's on oxygen because he's got COPD. And this, you're putting a gun to your head, clever ads showing a cigarette as like a bullet. It's going to kill you. And then I don't know what the guy in the lower left is, but whatever. And the woman in the middle, she's pretty by conventional Western beauty norms, and she's laughing at smoking by what she's doing. And then in the lower right is the radical neck lady. So what she had was a cancer of the tongue or a bad cancer of the larynx. And Ian, the oncology in that field is very, very difficult because you got so many structures that are traversing the neck on their way to the head. Like a whole lot of your nervous system has to traverse that area, and you're both in and outside your spinal cord. And there's the carotid artery and other arteries, the vertebral arteries. You guys remember internal jugular veins. You got a whole lot of structures. Your thyroid isn't too far away, So there's a lot going on there. So these operations take forever, and the cancer spread can be into muscle tissue, and it can be into all kinds of stuff. So these people, their lives after that, they often are on a tracheostomy and they, have trouble breathing and they can't cleanse their lungs because of that. And they can't swallow when they want to eat. So they all lose a ton of weight. And the treatment usually doesn't even work. There's a very high mortality rate from this kind of thing. But she's pretty scary. She's had the left side of her jaw, like, it's gone. And so anyway, and this is not uncommon. You'll see plenty of patients who've been through this. So this is scary, and they put it on the ads and, seemed to work. So it worked. So it didn't work right away. Notice the effect really started picking up in 1980 or so, 16 years after, you could say, the campaign started in 64. This is how it is with public health. It takes a while. It's not 100% effective. Even by 2003 at the right end, there's still a lot of cigarettes being shipped, which is the best measure of how much smoking is going on. It's the best one we have. And so it's an economic measure, but it's a good one. Anyway, so it went down from 12 to around 4.5. So it's, 60% decrease or something like that over those years. 12th graders were a tough group. That really didn't start to budge much until 1998 or so. And that's continued there. And there was a big increase in incidence among females only in the 2000s. And sometime around 2010, it had to do with obesity, that it got spread among girls that if you smoked, you would be less overweight or something like that. Anyway, so the female adolescent population was a special group that did get attention and seemed to help. Anyway, so here's smoking in the US, big victory. Lessons, industry will fight every step of the way, and they did. Every step of the way, every law banning cigarettes on airplanes, every bit of it got fought. Importance of data, multifaceted strategy, and changing the notion of what is socially cool. So that's all I'm going to present. But I wanted to ask you guys, when you hear, from what you've learned today, what we've covered, when you hear a gun rights person who's, wants no infringement of the Second Amendment, when you hear them say, oh, all you public health people want is to take away our guns, what's your response to that? I don't mean what you say back to them, that's one thing, but what you think in your head. They're accusing you of that all you want to do is take away their guns. And let's say you're public health, you're interested in preventing childhood deaths from firearm injury, or just total deaths from firearms, the leading cause of death in many states. And I think it's maybe the leading cause of injury death in people under 44 years old. You only want to take away my gun. Go ahead, Shay.
I personally, I quite like President Barack Obama's response to this. I don't remember verbatim his words, but when he was president, I think he was asked something along these lines during a town hall when this was more of a, I don't know, people have kind of given up on this issue now, but this was more central to the news and mainstream back then, maybe at that time. And he responded by saying, comparing it to how our public health professionals address the problem of car accidents in this country, that at one point when cars started to become popular and were showing up everywhere, there was a lot of accidents. There was no standardization to the technology. There was no guidelines on how to build roads and all this stuff. And they put money into studying why accidents happen so frequently, how to make cars safer, how to design roads so that embankments don't encourage cars to tip over and things like that. So I think that public health coming to address public health issues, which is what gun violence is, will only, it's not, I mean, what comes to my mind, I don't really know how to express this best to someone who's opposed to this, but I really don't think it's about taking away guns. It's about making them safer and making like everyone safer around them. In the same way that we didn't take away cars to make cars safer, we made them all have seatbelts, and we enforce speed limits and something along that line. I think is how I would think about it.
Any responses to that? I can argue against you in just a second, but anyone want to respond to that? He wants to make guns safer and doesn't want to impair people doing what they want to do, in their spare time or whatever. By the
I
way, I
definitely.
agree with you that politically it was a clever response, but I'm part of
Yeah,
Obama.
yeah, very much so.
Yeah.
I was just gonna say that I definitely agree with everything Jerry was saying. Ultimately, to answer the question, I feel in regard to that statement, I feel kind of frustrated from a public health point of view because it feels like it's kind of minimizing the full issue into just this one incorrect statement of, oh, the purpose that people who are advocating for gun safety, they're the overarching goal isn't to take away your rights, it's to stop children from getting slaughtered in schools and all of this senseless gun violence. So it's definitely frustrating to hear. I definitely agree with Jay's point about the cars. I thought that was a really good comparison. But also I feel like that it's just there's a difference between wanting to take away someone's rights completely and take away their guns versus just implementing more safe practices and more background checks kind of So I don't know.
Okay, anyone else? All you want to do is take away my guns.
I feel like there's kind of a paranoia that is like encouraged politically so that there isn't like this conversation between parties where we could come to like a some kind of compromise or like have better regulations. It has become such like a political like a way to grab voters. And so like that paranoia and refusal to like even have the conversation is kind of encouraged in like the larger dialogue.
Anyone else? God, you guys are going to force me to play devil's advocate, but I don't mind. Anyway, okay. All you want to do is take away my guns. I have two types of responses. One is, I am a public health practitioner. I will never close my mind after I've come up with one single strategy. I will come up with at least 9 strategies for each little triad on this matrix, and hopefully multiple entries within each one. And I'm coming up with a multifaceted strategy. Number one, you accuse me of something that would be absolutely anathema to a public health practitioner. I want to use every strategy. I want guns to be made safer. I want to ban the sale of bullets. That would be really good. And frankly, I don't think your damn gun is sacrosanct. You know, I would take away your guns because you can find another hobby. Try playing chess or backgammon or go running and get some damn exercise instead of just playing around with your guns every day. I'll stop. Anyway, so, I think there are arguments in all of these, but, reducing the population of guns in a country is a pretty effective strategy overall worldwide. Some countries manage to have a lot of guns and not kill each other with them, Switzerland and Canada, but, for the most part, there's a pretty high correlation. And, and as guns become more prevalent in places like Brazil and El Salvador, it's gone really badly. There's, just terrible outcomes, murders and anyway, but the main point the main point I'm making. Yeah, I'm good with mental health interventions. I'm good at picking out the people, if you could, who are who are going to murder 25 children in a school in 3 weeks. If we could pick out those people, I'd be thrilled. It's fine. We can use other strategies. But no, I don't have just one strategy. And maybe we could do something about the whole gun thing. And I don't know. That's just my feeling. Anyway, but the main point I'm making is that you come up with a multifaceted campaign such as that, which is the one used for tobacco. And this is done when there was enough of a consensus that it was a good thing to do, that you had an industry that was fighting every step of the way, but enough of the public was on board to do something so that you could have a multifaceted campaign that was effective. And what you have now with guns is not merely an industry which is funding the whole anti-gun control movement. The firearms industry is an incredibly important funder of this whole Second Amendment right thing. So that there's a whole lot of money opposing gun control, and there's not a lot of money supporting it. And there's not a social consensus because one of our major political parties, only after 1977, went into bed with the National Rifle Association. And the National Rifle Association completely changed from being let's go hunting and have fun or work on target practice and doing benign things to taking a much more aggressive stand. And with that marriage in 1977 between the transformed NRA and the Republican Party, you now had a whole political party that, well, wasn't going to do anything, and that sparked this entire movement. So now even the Democrats in Congress are unwilling to, do anything meaningful. So so, this is yet another example of how in how, inevitable and ubiquitous the intrusion of politics into public health are. And anyway, so the rest of the internship, when we're talking about health financing, your opponents are sort of clearer, and the population isn't against you as they are with this. People really do want to have health coverage for everybody and not pay so much for drugs. So the opposition to, useful change is quite different from what we've been facing in these public health campaigns.